Hello and welcome to the Minds on the Frontline Podcast, a podcast dedicated to meaningful conversations that inform, educate, and inspire frontline workers, their families, and the public. Our mission is to shed light on the mental and behavioral challenges faced by those on the front lines while providing valuable insights and real-world solutions. Minds on the Frontline is brought to you by the Frontline Strong Together 5 program. FST5 provides streamlined access to behavioral and mental health services and crisis resources for Michigan's Frontline 5 workers and their families. This includes all professional, part-time, and volunteer firefighters, EMS, law enforcement, corrections officers, and 911 dispatchers in Michigan and their immediate family members. First responders and mental health experts collaboratively created FST5 to provide 24/7 live support, effective resources, and cutting-edge services to prevent and alleviate PTSD, anxiety, depression, and other frontline work-related mental and behavioral health challenges. Need help now? If you are a frontline worker in Michigan or an immediate family member experiencing any crisis, whether it's work-related, substance abuse, depression, relationship, finances, or any other, reach out by calling 1-833-34-STRONG or go to fst5.org for more information. I'm Jeff Lassers, one of your hosts. I'm a professional firefighter, paramedic, educator, and content creator. Minds on the Front Line is co-hosted by Mike Mattern, also a professional firefighter and paramedic. In addition, Mike is a peer support team member for his fire department and the FST5 program. In this episode, we welcome Dr. Rebecca Sripada, a leading clinical psychologist, researcher, and associate professor in the Department of Psychiatry at the University of Michigan. Dr. Sripada is also a research scientist at the VA Center for Clinical Management Research and has spent nearly 20 years specializing in PTSD treatment and recovery. Her research focuses on improving access to effective PTSD treatments for veterans, first responders, and healthcare workers. Today, we dive into the PRIME study, which stands for PTSD Recovery Implementation in Employee Assistance Programs. This study aims to bring effective PTSD treatment directly into EAPs for first responders and healthcare workers, making care accessible where they might seek support. During our conversation, we explore how PTSD manifests in first responders compared to the general population, examining the ongoing exposure to trauma and its long-term effects. We also discuss the barriers that prevent many first responders from seeking mental health care, addressing the stigma that often keeps them from getting the help they need and deserve. Finally, we take a closer look at the PTSD treatments being evaluated in the PRIME study, assessing their effectiveness and how they can be integrated into accessible care for those on the front lines. This episode offers valuable insights that could transform how PTSD is understood and treated in first responder communities. If you or someone you know is struggling, this conversation provides hope, education, and a path forward. Please check us out on YouTube, Instagram, Facebook, X, and LinkedIn, and make sure to like and subscribe to all Minds on the Frontline Podcast social media channels. Thank you, and enjoy the show. Good morning.
Morning.
Good morning.
How are you?
Good. Happy to be here.
Dr. Sripada, Becca, please introduce yourself. Who are you? What do you do? And where do you do it?
My name is Rebecca Sripada. I'm a psychologist. I am an associate professor in the Psychiatry Department at the University of Michigan. I'm a research scientist at the VA Center for Clinical Management Research. So I have a joint appointment at U of M and at the VA, and I study post-traumatic stress disorder and ways to improve our treatment for PTSD, ways to improve access to treatment, particularly for folks who have high rates of trauma exposure, high rates of PTSD, and don't access care as much as we think they might need it, like first responders.
Yeah, as much as they might need it, they may not self-recognize the need for clinical options that are available to them.
Yes, that's, I think, one factor. But I mean, mostly I'm just trying to bring our effective treatments to people who might benefit from it and make it fit their jobs and fit their needs.
So right now you're working with first responders and veterans on some stuff you're doing, but you've been working with veterans for quite a long time. So what led you to specialize in PTSD research specifically with those veterans and then move on to first responders?
So I started working with veterans years ago in graduate school. Veterans have high rates of trauma exposure, high rates of PTSD. The thing about PTSD that drew me to the field is that it's a really disabling illness. It really interferes with all areas of someone's life. But the therapy options that we have for PTSD, if given the correct therapy, if given an effective therapy, individuals with PTSD can just make these huge gains and really recover and really see improvements in all areas of their life, from their social functioning to their family interactions, to their irritability, to their sleep. And it's just an amazing thing as a therapist to be able to work with someone on something that they experienced maybe years ago, or maybe something that they've experienced repeatedly, and have them make these changes and make these gains that when they've been struggling for so long with something.
So before we go on to the PRIME study, I want to kind of set the first principles of PTSD. I think it'd be best for you to give us your best clinical layman's term definition of PTSD.
So post-traumatic stress disorder has different domains, and it shows up for different people differently. But one of the core features of PTSD is what we call re-experiencing symptoms. So that's when people have intrusive thoughts and memories and dreams about traumatic events that they don't want to be having. And this is these thoughts and memories coming up just untriggered, out of the blue, when you don't mean to be thinking about it, in a way that really gets in the way of what you're trying to do, what you're trying to accomplish in that moment. And this is really disruptive for people when they're trying to work, when they're trying to be with their family, when they're trying to sleep. So these re-experiencing symptoms are kind of the key feature of PTSD. Another key feature of PTSD is avoidance. So avoidance of thinking about the memory itself, avoidance of things that remind them of the memory or the memories. And again, this can really interfere in someone's life, especially if they experience trauma on the job, because it makes it hard for them to do their work, hard for them to be close to the places where they experienced traumatic events, and hard to be around the people that were there at the time or people that remind them. So the avoidance is like another part that is really disabling. Other features of PTSD are negative thoughts about yourself, other people, and the world. Oftentimes after trauma or after certain traumas, individuals will have a lot of self-blame and guilt that they're carrying about things that they did or didn't do at the time of the trauma. And these things can fester over time so that people continue to blame themselves and continue to think about the woulda, shoulda, couldas and the if-onlys, second-guessing the choices they made and really beating themselves up over months or years for things that happened at the time of the trauma. Other symptoms that people experience when they have PTSD are hyperarousal and hypervigilance, so feeling always on guard, always on edge, and hyperstartle, so having like a very strong response to being startled, irritability, and again, these will show up at home, at work, and really get in the way of relationships.
That seems pretty awful.
That's a pretty comprehensive overview there of PTSD.
No wonder she's trying to do something about it.
Yes. So why don't you explain what the PRIME study is and kind of how it focuses on first responders and people in the healthcare world as well?
Absolutely. So the PRIME study stands for PTSD Recovery Implementation in EAPs. And the goal of the PRIME study is to try to bring effective PTSD treatment to healthcare workers and first responders by providing it directly in their EAPs, employee assistance programs. And we got the idea for the study during COVID because during COVID, first responders and healthcare workers were experiencing even more trauma than usual. And there was a clear need for services for first responders and healthcare workers at this time of increased stress and increased trauma exposure. My colleagues had recently adapted one of our first-line treatments for PTSD to be available in a brief treatment setting, specifically in primary care, because standard first-line PTSD treatments are typically pretty time and resource intensive. So they typically take place over the course of 3 to 4 months, and require 60-minute sessions. But a lot of treatment settings aren't set up to deliver that kind of length and intensity of care. And so my colleagues had recently adapted this first-line treatment to be available in a brief setting in about 6 sessions, each of which could be as short as 30 minutes. And so we took that opportunity to adapt this further for the EAP setting. So employee assistance programs are available at most large organizations operating under similar constraints as primary care clinics, because they can really only offer 6 sessions and they can't do super long sessions. So 30 to 45-minute sessions are really good for EAPs. So we took the opportunity to propose to deliver this adapted intervention in the EAP setting and compare it to standard services. So taking a look at whether this adapted PTSD intervention can provide a method for first responders and healthcare workers who might not otherwise have access to effective care to receive effective PTSD treatment right in an embedded service delivery setting.
So it's in one way a good net to cast to find people that could use this clinical setting and these treatments, as well as a efficient way to maybe optimize that time and do it in a condensed fashion. Is that correct?
Yeah, and bringing the care to them instead of asking them, putting the onus on them to find the care in the community.
So you're almost arming these EAPs in these locations with more resources to help the people that are going to walk in their office, essentially.
Absolutely.
And a more friendly, like
Right.
first responder friendly.
You're meeting
You know
them,
what I mean?
yeah,
Yeah,
you're
you're
meeting them where they're at. They're
Yeah.
willing to go to that place, and that place is now saying, well, we can also do this,
Yep.
which is identify maybe some of the PTSD symptoms and then walk them through this process.
Exactly.
Awesome. So let me ask you this. We're talking about specifically veterans, first responders, and healthcare people that deal with vicarious trauma, see bad stuff all the time, or just get beat up by our healthcare system in general, or our emergency response system in general. So how does PTSD present differently in these types of the population you're working with than the general population?
So one thing that's notable about first responders is that they're continually experiencing trauma. So, for some populations or some types of trauma, like an auto accident, the trauma is a single incident trauma. First responders experience trauma on a regular basis. And so that is a major difference because you're not just working with one traumatic event, you're working with many traumatic events, and you're not working with something that occurred exclusively in the past. You're working on something that may be ongoing in some respects.
And on top of it, probably getting new ones dumped on top of the old ones while you're working on the old ones.
Yes.
So it's got to, it adds to that complication.
What about other complications on top of that, like depression, alcohol use, chemical enhancements, outside stimulus, basically?
Yeah. So first responders also are at elevated risk for other mental health concerns as well. So they have, rates of PTSD in first responders are like twice as high as they are in the general population. But also first responders have elevated rates, as you said, of depression, alcohol misuse, sleep disruption.
Yeah,
and
you're telling me.
Yeah.
I'm preaching to the choir here.
Yeah, exactly. Yeah.
Oh my God.
Yeah.
Yeah.
I could take a nap right now.
Yeah, and what's rough is when you become a parent, when you get off shift, and as a parent, when you get home, it doesn't matter how tired you are, right? Sometimes things are going on that you have to be a part of, and then you got to go back to shift the next day. And so I just had a 3-day that I felt like a zombie, and last night was my first real night of sleep in about 4 days. And I was like, I feel so much better. I'm like, normal people do this every day?
Yeah.
They have the option every day? So, yeah, you're preaching the choir there.
Yep.
That alone, just the sleep disruption, I feel like can just induce mental problems. Like ask any parent, like I'm saying again, or anybody with a sick family member that they got to be up with all night. That lack of sleep will drain your emotional capacity and its battery down to zero.
Yeah, absolutely.
Yes.
And there's this reciprocal relationship between sleep disruption and PTSD, where sleep disruptions, worsen your susceptibility to PTSD, and then PTSD can further disrupt your sleep. So it's a vicious cycle.
A class 1 carcinogen.
Yes.
Lack of sleep.
Yes.
It's not a good thing. We got to figure this out. Okay, but what about, so help me understand the difference between PTSD and acute stress disorder. I think a lot of times you're going to help me unconflate these words sometimes. And I think sometimes people use the term PTSD a lot without it being diagnosed. And I don't want to diminish those people's feelings or what they're going through, but help me understand that stratification of the things that might seem like PTSD.
So I think people sometimes throw around the term PTSD kind of colloquially when they're talking about dealing with stressful events, like, oh, I have PTSD from that. And that I would distinguish from a clinical diagnosis of PTSD, because a clinical diagnosis of PTSD or clinical symptoms of PTSD are in all those areas I talked about, like the re-experiencing symptoms, the hypervigilance and hyperarousal, the disruptions in thoughts about the self. So it's kind of like a total package, not just experiencing a stressful event, because people, especially first responders, are incredibly resilient. They experience stressful events all the time, and most of the time don't have PTSD. So just because you experienced a stressful event does not mean you have PTSD. And the other piece is that acute stress disorder, the difference between acute stress disorder and PTSD is really just a matter of time since trauma. So if it's been less than 30 days since a traumatic event, we would not diagnose someone with PTSD. We might diagnose them with acute stress disorder if they have some of those symptoms. And most of the time, people recover from that. So if you look at, there's some interesting studies that take a look at PTSD symptoms over time in people that experience traumatic events. And it turns out that right after a traumatic event, in the days and weeks following a traumatic event, most people will have some PTSD symptoms. But then for most people, those symptoms subside over time. For people with PTSD, they don't. They don't subside. In fact, they may worsen over time. So PTSD can really be thought of as a disorder of recovery, actually. The symptoms of PTSD are not unusual. What's unusual is for them to persist more than a month after trauma.
So it's more you all experience the same thing, or you experience this trauma. The PTSD comes in more where you weren't able to process it, you weren't able to take care of it, whereas the acute stress disorder is you had that, say, 30 days to, okay, now I'm starting to improve. But after that, it's actually...
You were able to get over it.
Yes.
In the general sense. I don't mean it like coldly, but
yes.
You're able to go look back at it and think about it without the amygdala firing.
Yeah.
Yes.
Essentially.
Yeah.
Within those 30 days, a lot of us are not looking to go get help, right? We're kind of like, we can deal with it. From a clinical perspective, what are some of the barriers and the biggest challenges that you've seen face the first responders, the veterans, when it comes to actually getting PTSD treatment and other kind of mental health illnesses that they need to get taken care of?
I think the number one barrier is stigma. There's this idea that going to seek help is a sign of weakness, and that being able to tough it out on your own is preferable than talking to someone about it. And then I think there's another layer for first responders of not wanting to call into question your fitness for duty, and wanting to be able to continue to do your job and not have anyone question your ability to do your job. There also are additional barriers, like logistical barriers, like where do you go to get help? Where do you go to find effective treatment? That's one of the things that I'm trying to address with the PRIME study and future iterations of the PRIME study. There are also just barriers in terms of time cost. When you're doing therapy and when you're doing the homework assignments between therapy, that's opportunity cost when you could be doing other things.
You got to be invested in it seems. And that's a hard thing to ask somebody to invest in something they're wanting to avoid. When avoidance is one of the key markers of PTSD, and it requires your complete lack of avoidance to go after it, it's like a sick paradox.
Absolutely. Avoidance is one of the hallmark features of PTSD and one of the engines that keeps PTSD going. And so going into therapy and doing the therapy work runs directly counter to what you're experiencing when you have PTSD symptoms.
And it already hurts a lot. And now you're asking me to get more uncomfortable?
Well,
that's a big ask.
I think it goes back to the whole stigma portion. That's a big avoidance, is if I admit that I have this, then I'm what I think.
It's certainly making the thought everything else worse. Yes. On top of this, so I also have the thought of me thinking about you thinking about me needing this, and the you in the general sense, right? Or the self-imposed prison that can be stigma. Like, you're the only one worried about this. We all think you need help.
Well, I think you hit the nail on the head. I mean, I had a portion of my life where I had PTSD after a run. I didn't want to admit that I had something going on. You know what I mean? And that moment of when you went to actually seek help, I always tell guys, like, I felt about an inch tall. You know what I mean?
What stopped you from asking for help?
The stigma. How other people were going to look at me, Same thing on the job. You know, I mean, you never want to be the
common.
weakest link in there, so you hide it. You know, no one ever knew that was going on because you can hide it real well. You know what I mean?
It was long ago enough too to where even locally with FST5, you didn't have the support around you.
No.
This was a much different time.
That's it. And I think that's what people.
I shouldn't say that. You didn't have the obvious support. There's probably more support around you than you realize, I think, a lot of times.
Yeah.
Because the negative thoughts and the negative voices are always louder than the positive ones.
Yeah, but I think it was that, but I think it was we didn't have anything specifically for mental health.
Yeah,
you know
you didn't know where to go.
You didn't know where to go.
So it adds to the stigma that, like, not only do I need it, I don't even know where to go, and now I feel helpless.
Yeah.
That's where I'm kind of feeling that.
That and you felt like you were less of a firefighter, less of a person.
Less of an adult, less of an alpha.
Like it was a weakness to ask for help, right? But when you look back at, I look back at it, that was years ago. I mean, I look back at it now. It was actually like the strongest thing I ever did. Yeah. Because it was like that time where you finally were like, all right, I'm not going to let this get me anymore. You know what I mean? But at the time, you feel so tiny.
And that goes back to what you were saying, is that the hallmark of avoidance, the discomfort of having to face it, man. So okay. Yeah. So what made you say, I'm sorry to diverge from the doctor over here, but I think this is a really good conversation. No. What made you
Let's get back to the doctor.
Yeah, I get it. So the first call, what made you actually make the first call?
Well, I think you finally got tired of feeling the way you're feeling. I mean, I knew I had something like that. The run that really got me, I knew it got me, right? It wasn't like any other one. I was more irritable, the hypersensitivity, you name it. And I was on, the internet going, yep. It was finally like to the point where like, you're either going to get better or you're going to lose everything, basically. Right. You know what I mean? A lot of people get to that point where you don't start looking until it's rock bottom.
Yeah.
But another thing that helped me was one of the guys who was on the run. We were riding in the rescue one day and he started talking about how he was talking to a therapist about that run. And it was like, holy shit, I wasn't the only one.
It almost gave you permission.
It almost gave me permission. And that's honestly, no bullshit. That moment was where I realized peer support works.
Because you literally got it without him trying to give you peer support. A peer supported you by showing you the boogeyman isn't real.
Yes. That was where the concept of peer support made sense, because it was like, just by him saying he went to go he was seeing a therapist for that run, made it okay for me to go.
Not a similar run, the
exact run.
And he was admitting he needed that help. And
he admitted he needed the help.
So do I.
Yes.
Did you feel relieved right then?
I
can imagine you going,
dude,
okay.
It felt about like 3,000 pounds were lifted off my shoulder.
Just in that moment.
Just in that moment.
Not even talking to a clinician at this point. You just feel okay knowing that it's okay, that you're not okay.
Yes. And that was the exact moment, I'll tell you right now, it's the exact moment I realized what peer support was and how it worked. Because it changed everything. Like from that point forward, I could talk to that guy about that run, whereas I couldn't talk to anybody else about that run. Huh. And when he said it, I'm like, it was a relief. It's like, I'm not the only one.
Permission. It feels like permission, what you're describing.
Yes, absolutely.
What do you think, Doc?
I think the permission and the normalization, that is huge, to be able to hear from other people that they're going through something similar and that they're also
surviving.
Seeking help.
Yeah.
And surviving.
Yeah, right. Well, you're going to be okay. I'm doing it. And to see the comfort in just saying that, wow, that's huge. So people like that of Mike have gone through this, and you've probably heard that variation of story in 1,000 different ways, and I don't know how you deal with all these stories in your head, but you're doing pretty well. But so what are the types of PTSD treatments that you're evaluating in the PRIME study, and how do they compare to other options that are out there?
So the type of therapy that we're testing in the PRIME study is called PE for primary care. That stands for Processing Emotions in Primary Care, which is a version of the first-line therapy, prolonged exposure therapy. What we do in PEPC is we tackle that avoidance in two key ways. We have a procedure where we go through the story of the memory, and the first responder or the veteran, whoever's going through the therapy, will walk me through the story of what happens, because what often happens to individuals with PTSD is that they try to push away this memory and try to push it down. And what we need to do is process it and confront it. The analogy that I use is that it's like a really messy closet, And what you've done is you've stuffed everything that in that closet and slammed the door shut because you don't want to handle it. But because it's so full of stuff, the door keeps popping open and all the stuff from the closet keeps falling out into the hallway. And it's startling every time that happens because you don't know when it's going to happen and you don't know what's going to come out of that closet. So what we do in PEPC is we open up that closet door, we take a look at everything that's inside there, we throw away the things that don't belong, we organize the things that do belong, so that way you know it's in the closet. That door is much less likely to pop open, and if it does, it's not scary because you know what's in there and you know where things go and how to put them back on the shelf. That's one of the core features of PEPC. The other one is starting to systematically and gradually confront the things that you've been avoiding because of the PTSD or the PTSD symptoms. So oftentimes people with PTSD will avoid places, situations, people that remind them of trauma in some way. So if it's, I work with a lot of people who have traumatic events that involved kids in some respect. And so for those individuals, being around kids of a certain age or a certain gender, going to playgrounds, taking their kids to play dates, even maybe being around their own kids can be very challenging, and because it reminds them of that traumatic event. And then it's really upsetting because they want to be able to do things with their kids. So we start to systematically, gradually confront those situations by starting off slow, starting off easy, and working our way up, but doing it in a specific way so that individuals can build confidence about their ability to handle these situations and really take their lives back from PTSD.
That's pretty cool.
No, I mean, it's awesome what you guys are doing with it. I mean, it really is. By doing this, what have you seen that were some of some promising trends with the treatment, success-wise, with it so far?
Yeah, you probably can't talk about data yet. You're still in the middle of this, but is there
whatever
anything
you
of
can
interest?
talk about?
Yeah.
So we did a pilot before we started this larger project with healthcare workers in Michigan, and found that after just 4 sessions of this therapy, first responders and healthcare workers were experiencing a significant decrease in their PTSD symptoms. And the way we measure it is through this self-report checklist. It's like a 20-item survey about all those different symptoms of PTSD that we talked about earlier. And we give this to people a few times during the therapy, and found that after just 4 sessions of this therapy, individuals are experiencing a big dip in their symptoms. So that was very encouraging to us. That's what led us to do this project that we're doing now. But what we'll do in this project that we're conducting right now, the PRIME study, is we'll compare the changes we see in PEPC to what we see in treatment as usual. Because if the care that EAPs are delivering already is sufficient, then we don't need to change that. So that's the difference between an open pilot, what we did before, and the randomized control trial that we're doing right now. We want to really make sure that we're bringing added value.
Yeah, you're not just adding another tool exactly like it.
Yeah.
You're having a nuanced tool that, again, is capturing all of the right people and offering a condensed fashion to kind of get away from that avoidance and into treatment.
Yes.
That's really cool. And now, what about any disappointments?
I would say the number one disappointment is that we haven't seen as many people come through the EAPs as we expected, because we know there are such high rates of trauma exposure, both in first responders and in healthcare workers. We anticipated that a lot of people coming through the EAP would meet criteria, would have some PTSD symptoms, and would be able to enter the study. But turns out that not as many people as we anticipated are coming to their EAP to work on their PTSD.
The stigma tends to leak over into your employer's EAP, right? And again, there's a million EAPs out there that are amazing. There is a thing where you're contacting your work's contracted place that prevents people from reaching out. And that is a sad thing that stigma of the stigma exists.
Well,
right?
they all think that they report back to the city
Right.
and everything's going to be figured out. And on the peer support side, I'll tell you, that's where we run into problems, because they're afraid that the city's going to find out, or their municipality or their company or whatever it might be. There is that stigma. They're like, hey, I'm afraid to go use the EAP.
Now, in your process, can you weigh in a little bit about that and what can and can't be shared with that EAP to kind of help those people maybe ask for help from their EAPs? Because there's a lot of really good ones out there.
So EAPs are under no obligation to share any information with the employer, and we'll tell you up front that they're not going to share any information with your employer. You do have good privacy when you go to your EAP, but I think you're right. A lot of individuals still worry that if they go to their employer contracted EAP, that somehow that information might get back to their employer.
And not even the fact of what was discussed, but the fact that they went there.
Yes, that's all kept confidential.
They can't be balanced in some people's minds. They just can't take that chance. And I get it. I totally get it when because you're not talking about a person who's in a logical place emotionally. You're already talking about somebody who's having some problems on stigma, maybe not reaching out. And they're like, but I can't let my employer find out. And so I certainly understand why this paradox exists. I just wish there was a little bit cleaner way to access that. So speaking of stigma, what are some effective ways to reduce that in your professional opinion?
I think the things that the two of you do are fantastic. Talking about it, I think, is the number one tool to fight stigma. Normalizing it, sharing that it's something that a lot of people struggle with, and that getting help is effective and getting help is a positive thing to do, and having leadership talk about it as well, and be vocal about supporting it.
Is it common to hear from your patients that successfully stick with it that the hardest thing was getting over the barrier of just asking for help?
I think that a number of clients do say that that is one of the most challenging things, but tackling your PTSD is also challenging in and of itself, and the therapy that we used in the PRIME study is hard work, because you're confronting things that you've been trying very hard not to confront. So I do think that being in a spot where you are ready to tackle this and ready to work on it is crucial to making gains.
When we're talking about the support with it, one of the biggest things that people look for support from is like the leadership of their place, their administration, their company, whatever it might be. What can we say to those frontline leaders that really, how they could best support their personnel when it comes to like not only PTSD, but overall mental health care, recovery, the whole deal?
Before they need it and when they need it.
So a number of the EAPs that we work with told me about this annual checkup that they do with first responders, maybe healthcare workers too, but I've heard about it mostly in the context of EAPs that work with first responders, where there is a suggested annual checkup that you do with your EAP, similar to what you would do for like a primary care visit, an annual physical. It's an annual mental health checkup that is a way to normalize the process and also kind of just like overcome the hump of actually going and figuring out the logistics of
getting on the ride.
Yes.
Pulling back the curtain and seeing the man behind the curtain.
Yeah.
Logistics is so much.
Well, I think that first time is just the scariest.
Right.
Walking into that office the first time is
Is
about
this
as
doctor gonna
scary
suck? Is
as...
this doctor going to be a douche?
Yeah, well, not only that, but like what's going to happen to me? How, you know what I mean?
Yeah.
That type of thing. So I think
They're going to give me a shot.
Yeah,
Like a little kid.
I don't want to talk about it. Yeah.
Yeah. So I think something like that could be very beneficial.
Yeah, absolutely. I think it gives them a taste of it without, being very scary.
Right.
It's kind of here, the first one's free.
Right.
You know what I mean?
Exactly. There's no obligation to follow up, but now you know how to do it if you want to.
Yeah.
So the last 5, I would say, years in the first responder community, really since COVID and humanity, we've put a spotlight on mental health. There's certainly been a lot more resources allocated towards the first responder communities and a lot more advancements into removing the stigma. So what do you see, hopefully, with this momentum continued and maybe some interest built on these investments we're making? What do you see for the treatment of PTSD in the next 5 to 10 years? I
think continuing to flex the therapy to make it tailored for first responders is important. Because as we talked about, first responders are a unique group of individuals that have unique needs with regard to their PTSD treatment and mental health treatment. And I think figuring out different settings and different provider types will also be very beneficial in helping make sure that this meets the needs of first responders.
Awesome.
No, that's good. Now we're going to switch gears a little bit. You're talking to the actual first responders now. What would your message be to them listening right now of our Frontline 5 who might be struggling with PTSD?
So I would say for families and colleagues, if you notice that your loved one has some of these symptoms, encourage them to seek treatment, because that, I would say, is the number one reason that people say they've decided to seek treatment is because their loved one keeps hassling them about getting care. They don't want to do it for themselves, but they want to do it for their families, for their spouse, or for their kids. So if your loved one is struggling, stay on their case, because I think that's a really powerful way to encourage them. It's because they love you and they want to be there for you. And for first responders, if you notice these symptoms in yourselves, I would say be proactive about it, because if you've been experiencing this for a while, it's unlikely to get better on its own if it's been going on for years, and it will have impact on your mental health and on your physical health. So get treatment at your EAP, talk to your peers, find a therapist in your community. There are effective treatments. That's what got me into this field, is that PTSD is a very debilitating illness, but it is an illness that you can recover from, and the therapies are very effective. So don't suffer in silence.
And where can they find more information on the PRIME study? We have many people in Michigan listening to this. How can they get a hold of you to be a part of this?
We have a website. You can go to the PRIME website. You can go to the University of Michigan Psychiatry Department webpage. We've got information there.
If you just Google PRIME study, I know it comes up right at the top too.
Oh, perfect.
Yes.
Google PRIME study.
Well, thank you very much, Doc. We love having you on here, and we look forward to working with you more, so people know. FST5's hooking up with our friends over at the Maize and Blue via Dr. Sripada to work on advancing this study.
Yes, a new project.
Yes.
So we'll have to have you back when we can talk about it, and it's updated, and it's exciting. Let me put it that way.
Very cool stuff.
It's actually very cool.
And she's one of the culturally competent clinicians. So we appreciate you and your 20-plus years of working with veterans and even first responders. We appreciate you taking the time to care to work on this stuff through PTSD and helping our brothers and sisters in this.
Yeah, I'm honored to be working on it with you.
Thank you.
Thanks. Have a good day.
Thank you for listening to the Minds on the Frontline podcast. We have more great content coming out soon. Please check us out on YouTube, Instagram, Facebook, X, and LinkedIn. And make sure to like and subscribe to all Minds on the Frontline podcast social media channels. Thank you, and have a great day.